Welcome to The Explainer. Today, we are cracking a classic topic for the FRCS vascular viva, and that's the evidence for sex differences in EVAR outcomes. Having a really polished, evidence-based answer for this is absolutely critical.
So this is the question, and trust me, it's a classic for a reason. It's designed to test your grasp of the evidence, your ability to quote key data, and most importantly, your understanding of how it all impacts your clinical practice. You get this right, and you're signaling to the examiners that you're already thinking at a consultant level. So let's build that perfect answer.
So, where do you even start? A strong answer has to be anchored in the highest quality evidence we've got. And this is your cornerstone. Right out of the gate, you need to cite a specific, high-impact paper. In this case, it's the 2020 meta-analysis by Liu and colleagues in the Journal of Vascular Surgery. Doing that immediately tells the examiner, okay, this candidate commands the literature. It frames everything else you're about to say. The real power of this paper lies in its sheer scale. Look at this. It's a meta-analysis of 36 different cohorts. For its main mortality outcome, it includes over 74,000 patients. A patient population that large gives its conclusions some serious weight. Okay, a quick but crucial point. In your answer, precision is key. You've got to remember to use odds ratios when you're talking about those short-term outcomes and hazard ratios for the long-term time-to-event data. Getting that right matters. So, let's dive into those results.
First, let's build the short-term picture. What happens in that really critical period right after the procedure?
The top-line finding is just completely unambiguous. This meta-analysis confirmed that being female is an independent predictor of adverse outcomes in those first 30 days. Let's get into the specific numbers you need to know.
The first key statistic is 30-day mortality. The odds ratio here is 1.67. Now, what does that mean? It means women have 67% higher odds of dying within 30 days compared to men. That is a critical number to have in your back pocket.
And believe it or not, the difference is even more stark when we look at morbidity. For limb ischemia, the odds ratio is a staggering 2.44. That's more than double the risk for women. And this really reflects those technical challenges we often face with smaller caliber access vessels.
And it's not just limb ischemia. Women also had significantly increased odds of in-hospital mortality at 1.90 and renal complications at 1.73. If you can quote these three data points, you're showing a really comprehensive grasp of all the short-term risks.
Okay, so that's the immediate picture. But a consultant-level answer has to go further. It must address the long-term picture. So let's look at the data on survival and those late complications.
The tough news is that this mortality disadvantage continues long-term. The hazard ratio for all-cause mortality is 1.23. That means women have a 23% higher rate of death over the entire follow-up period. This really confirms that the increased risk isn't just some short-term blip.
Now, this is really important, and it's what separates a good answer from a great one. You have to also state where there isn't a difference. The analysis found no statistically significant difference between men and women for late endoleaks or for late reinterventions. Mentioning this shows you have a much deeper, more nuanced understanding of the findings.
So let's pull all that together. In the short term, women take a major hit, higher mortality, higher morbidity. Long term, that mortality risk sticks around, but interestingly, the rates of device-related issues like endoleaks and the need for reintervention, they basically even out. That is the complete narrative of risk you need to convey.
So far, you've presented the what. You've given the numbers. To get the top marks, you now have to explore the why. This is what shows that higher-level, analytical thinking.
Posing this question in your answer, maybe even phrasing it just like that, shows the examiner you're moving from just reciting data to real clinical analysis. So, what are the likely reasons?
Well, the truth is, it's multifactorial. It's a bit of a perfect storm. Women tend to be older and present later for intervention. Anatomically, they just present a greater technical challenge. We're talking smaller access vessels, which explains that higher limb ischemia risk and more hostile aortic necks. And on top of all that,
For a long time, the devices themselves just weren't optimized for female anatomy. And this is the critical link back to practice. You absolutely have to state that this body of evidence isn't just academic. It has directly changed international guidelines. Both the SVS and the ESVS now recommend a lower intervention threshold of 5.0 centimeters for women because we recognize their higher rupture risk at smaller diameters.
Okay, and finally, for that truly sophisticated, top-tier answer, you have to critique the evidence. You need to point out that this meta-analysis, as powerful as it is based on retrospective, observational data, not randomized controlled trials. There's potential for overlapping patient data from all those big national registries. And really importantly, the technology has evolved so much, so data from older cohorts might not reflect what we can achieve today with modern, low-profile devices.
Okay, we've built all the components. We have all the pieces of the puzzle. Now let's put it all together into that polished, structured answer you can deliver confidently, even when the pressure is on.
Here is your framework. Just follow these 5 steps. 1. Frame the discussion with that key paper. 2. Give the short-term numbers. 3. Give the long-term numbers, including the nuances. 4. Analyze the reasons and offer a quick critique. And 5. Conclude with the clinical impact. It's logical, it's comprehensive, and it's efficient.
So, to wrap it all up in a final, confident statement for the exam, you could say something like this. In summary, robust meta-analytic evidence confirms that female sex is an independent risk factor for worse short- and long-term mortality after EVAR. This is likely multifactorial, driven by anatomical and physiological differences. This evidence has rightly led to lower intervention thresholds in our clinical guidelines, and it absolutely mandates diligent, lifelong surveillance for these patients.